Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. Today, we're diving into one of the most critical cardiovascular concepts, inflammatory disorders of the heart. This includes endocarditis, myocarditis, and pericarditis. 3 conditions that may sound similar but differ greatly in their cause, symptoms, and nursing priorities. In this session, we'll uncover how infection, autoimmune reactions, or post-surgical inflammation can damage cardiac tissue, leading to life-threatening complications like valvular dysfunction, tamponade, or heart failure. We'll also break down classic signs such as friction rubs, murmurs, and fever, and connect them to the diagnostic findings you'll need to identify in both exam questions and clinical settings. By the end of this session, you'll have a complete understanding of how to recognize, manage, and prevent these cardiac inflammatory conditions using evidence-based nursing care. So grab your notebook, stay alert, and get ready to master this essential topic. Hold on a second before we dive into the next NCLEX topic. I need to share something urgent with you. If you are serious about passing the NCLEX on your very next attempt, you cannot afford to miss the ultimate NCLEX crash course. More than 100,000 students have already cleared their exam with it, and you can too. Why is this course different? Because it gives you everything in one place. Live interactive classes, recorded lectures you can rewatch anytime, 5,000 practice-style questions, 30 practice tests, ebooks and PDF revision notes, a student planner, and detailed NGN question explanations. This is your shortcut to success. Don't wait. Scan the QR code or click the link in the description now. You will instantly unlock free study content including NCLEX quizzes, PDF notes, and practice tests, plus access to our Telegram and WhatsApp groups with even more support. Now, let us move into another critical cardiac scenario. A client has recently undergone cardiac surgery and had a pulmonary artery catheter placed for hemodynamic monitoring. 2 weeks later, this client begins to experience fatigue, anorexia, and weight loss, leading the provider to suspect bacterial endocarditis. The question asks, which assessment finding documented by the nurse would provide the strongest evidence of an infectious process? Here are the options. Option A suggests chest pain. Option B indicates a dry cough. Option C highlights fever. Option D points to dyspnea. The correct answer here is option C, fever. To understand why, let us examine the expanded rationale. Fever is the most reliable and clinically significant indicator of bacterial endocarditis, as well as systemic infection. In this condition, microorganisms adhere to damaged endocardial surfaces or prosthetic valves, leading to the formation of vegetations made up of fibrin, platelets, and bacterial colonies. The immune system responds to these pathogens by releasing pyrogenic cytokines, such as interleukin-1 and tumor necrosis factor alpha, from activated white blood cells. These cytokines act on the hypothalamus, resetting the thermoregulatory center and producing fever. This rise in body temperature enhances immune activity, slows microbial replication, and serves as a clear signal of infection. In bacterial endocarditis, fever is often persistent or recurrent, may be resistant to antibiotics, and is frequently accompanied by chills, night sweats, splenomegaly, petechiae, and new or changing heart murmurs. Because it is both sensitive and specific, fever provides the strongest evidence among the listed findings that bacterial endocarditis is truly present. On the other hand, chest pain, while concerning, is more commonly linked to myocardial ischemia, pericarditis, or pulmonary embolism. Although septic emboli may rarely cause chest discomfort in endocarditis, It is not the hallmark of systemic infection. A dry cough is nonspecific and generally associated with asthma, bronchitis, or heart failure-related congestion. In endocarditis, pulmonary symptoms are typically more severe, such as septic emboli producing hemoptysis, rather than just a simple dry cough. Dyspnea, or shortness of breath, is a common feature in many cardiopulmonary disorders, particularly heart failure, but it does not specifically point to an infectious process, and therefore cannot be considered the best evidence when compared with fever. Here's the clinical takeaway. Also known as the STANCOAST pearl, fever should always be regarded as the hallmark sign of bacterial endocarditis, especially in clients with prosthetic valves, a history of intravenous drug use, or prior valvular disease. Other supporting findings include new murmurs, splinter hemorrhages under the nails, Osler's nodes, Janeway lesions, Roth spots, and most importantly, positive blood cultures. Nurses play a vital role in recognizing fever early, ensuring that multiple blood cultures are obtained before initiating antibiotics, and promptly advocating for treatment. Delay in recognition or treatment can lead to devastating complications, including systemic embolization, heart failure, and even death. Now, stepping into our next clinical scenario, we have a 63-year-old client with advanced liver cancer who has been admitted to the medical surgical unit with acute pericarditis. During a routine assessment, the nurse prepares to auscultate the client's heart and lung sounds. The question asks, which nursing action would best enhance the accuracy of auscultation findings in this client? Here are the options. Option A suggests asking the client to hold their breath briefly. Option B proposes turning off the television momentarily. Option C recommends positioning the client flat in bed. And option D involves palpating and locating the xiphoid process. The correct answer here is option B, turning off the television momentarily. Let us look at the rationale in detail. The most appropriate nursing action is to reduce or eliminate environmental noise. In a patient with pericarditis, auscultation accuracy is critical because one of the hallmark findings is a pericardial friction rub, a high-pitched, scratchy sound best heard with the diaphragm of the stethoscope at the left lower sternal border. This sound is subtle and can be masked by background noises such as a television or hallway conversations. By turning off the television, the nurse creates a quiet environment that supports accurate identification of whether the sound is truly a pericardial rub, a pleural rub, or another adventitious lung sound. This simple action improves diagnostic precision and ultimately supports better patient outcomes. Looking at why the other options are incorrect, option A, asking the client to hold their breath, may be used later as a confirmatory maneuver since a pericardial rub persists even when the patient holds their breath, whereas a pleural rub disappears. However, this should not be the first action, especially for a client who may already have respiratory compromise. Option C, positioning the client flat in bed, is inappropriate because lying flat can worsen pericarditis symptoms and dyspnea, and in fact, the pericardial rub is often louder when the client leans forward rather than lies supine. Option D, palpating and locating the xiphoid process, has no role in enhancing auscultation accuracy. It is more relevant in guiding procedures such as CPR or chest tube insertion, not in assessing pericardial sounds. From a clinical insight perspective, remember that a pericardial friction rub is pathognomonic of acute pericarditis, best heard at the left lower sternal border with the diaphragm of the stethoscope, while the client is sitting up and leaning forward. Noise reduction is the very first step before asking the patient to perform any breathing maneuvers. Exam questions will often test this subtle point. Always prioritize safe, simple interventions that improve accuracy without causing the client extra strain. Here's the clinical takeaway, also known as the Stancoast Pearl. In pericarditis assessment, the sound you do not hear may be as important as the one you do. Quiet the environment first, then confirm with positioning or breath maneuvers. Let us now shift our focus to a critical question about cardiac assessment. A nurse is evaluating a client with suspected left ventricular dysfunction, and the question asks which clinical finding most strongly indicates that the client's stroke volume is significantly reduced. Here are the options. Option A suggests that the client faints with activity. Option B indicates that the client develops hypertension. Option C proposes that the client manifests bradycardia. And option D states that the client has a bounding pulse, The correct answer is option A, the client faints with activity. Now let us break this down with a detailed rationale. Syncope or fainting during activity is a hallmark sign that cardiac output and stroke volume are not sufficient to meet the brain's oxygen demands. Stroke volume, which is normally about 60 to 100 milliliters per beat, represents the volume of blood ejected by the left ventricle with each contraction. When this volume is severely reduced, whether due to impaired filling from diastolic dysfunction, weakened contractility from systolic dysfunction, or obstructive valvular disease, the systemic circulation is deprived of adequate blood. During exertion, when the body requires more oxygen delivery, the inability to increase cardiac output leads to cerebral hypoperfusion and fainting. This is why syncope is such a powerful indicator of compromised stroke volume. Additional findings may include hypotension, weak or thready pulses, cool extremities, delayed capillary refill, decreased urine output, and compensatory tachycardia. In contrast, hypertension, as mentioned in option B, does not reflect reduced stroke volume. In fact, low stroke volume more often results in low systolic pressure, whereas hypertension is typically linked to increased afterload rather than ventricular pumping failure. Looking at option C, bradycardia further reduces cardiac output, but it does not directly indicate impaired stroke volume. Instead, it is more likely related to conduction disturbances or vagal stimulation. In cases of low stroke volume, the body usually responds with tachycardia rather than bradycardia. Finally, considering option D, a bounding pulse signifies strong ventricular ejection or increased preload, such as in fever, anemia, or aortic regurgitation. This is the opposite of reduced stroke volume, where the pulse would be weak and easily obliterated. To tie this together with a clinical pearl, stroke volume is determined by preload, afterload, and contractility. Any impairment in these factors will limit forward blood flow. The hallmark indicators of low stroke volume include syncope, hypotension, weak pulses, cold extremities, tachycardia, and decreased urine output. Nurses caring for such clients should prioritize safety measures, including keeping the bed in a low position, assisting with ambulation, and monitoring vital signs closely. And always remember the formula. Cardiac output equals stroke volume multiplied by heart rate. A drop in either component leads to compromised organ perfusion. Before we move on, I want to quickly share something that could really help you. You can now join our online NCLEX crash course, specially designed to help you pass the NCLEX on your very first try. This program has already helped over 1 lakh nursing students clear the exam successfully. And now, it's your turn. And here's the exciting part. We're giving a limited time 70% discount on the course fee. But remember, this offer is only for a short period, and seats are filling up fast, so don't wait too long. To enroll, just download our mobile app. You'll find the link in the description box below, or you can scan the QR code you see on your screen. This NCLEX crash course is truly a one-stop solution. It's a proven shortcut that helps you study smart and pass with confidence. So don't wait. Enroll now and stay ahead of thousands of other students in the race to pass the NCLEX. And yes, if you'd like some free PDF notes for NCLEX questions and a free NCLEX ebook, just download the mobile app. You'll get instant access to all those materials right away. All right, let's get back to learning. Here comes the next question. As we move on, let us consider a very important scenario that often comes up in the NCLEX exam. A 50-year-old client is scheduled for a heart transplant tomorrow, and during the preoperative night shift, the nurse is reviewing surgical preparation and postoperative expectations. The client, however, appears anxious and is unable to comprehend the information due to overwhelming fear and worry. The question asks, which nursing action is the most therapeutic and appropriate to perform next? Here are the options. First, the nurse could notify the physician to request an order for a sedative or hypnotic. Second, the nurse could provide the client with a detailed educational video about the surgery. Third, the nurse could wait until the client's spouse is present to re-explain the surgery. And finally, the nurse could encourage the client to verbalize fears and concerns regarding the surgery and rehabilitation. The correct answer here is option 4, encouraging the client to verbalize fears and concerns regarding the surgery and rehabilitation. This is the most therapeutic and client-centered approach. Heart transplantation is not only a complex surgery, but also a life-altering experience that brings with it intense fear of death, complications, prolonged rehabilitation, the possibility of organ rejection, and the lifelong burden of immunosuppressive therapy. When a client is too anxious to learn, the priority is not more information or more medication, but to address the emotion first. By listening actively, acknowledging concerns, and validating feelings, the nurse reduces anxiety, builds trust, and creates a supportive environment. Once fears are verbalized and the client feels heard, cognitive readiness improves, and they can better understand the education provided later. This aligns with therapeutic communication principles and the ANA Code of Ethics, which emphasize respect for autonomy and emotional well-being. Now, let us review why the other options are not correct. Although notifying the physician for a sedative may seem like it would calm the client, sedatives actually reduce alertness and interfere with learning. They mask the underlying emotional distress rather than addressing it, so they are not the first line of care. Providing a detailed educational video at this moment is also not helpful because the client is already too overwhelmed to process new information. In fact, it may worsen anxiety or confuse them further. Waiting until the spouse is present might seem supportive, but it shifts responsibility away from the client, who is the primary decision maker. While family involvement is important, the nurse's immediate role is to build a therapeutic connection directly with the client. Here's the clinical insight. Clients awaiting major surgery often experience so much anxiety that their ability to learn is impaired. The first step is always therapeutic communication, listening, acknowledging, and validating. Sedatives and teaching aids can help, but only after emotions are stabilized. Family support is valuable, but it cannot replace direct nurse-client interaction. The NCLEX strategy to remember is this: when anxiety prevents learning, always address emotions first, then move to education. Moving forward with the Stancoast Pearl. In preoperative anxiety, the heart of nursing care is not found in giving more information or more medication, it is found in listening. When fears are acknowledged, true learning and healing can begin. Let us now move into another critical scenario that often appears in advanced-level NCLEX questions. Imagine a client who is in the immediate postoperative period following an orthotopic heart transplant. The nurse is carefully monitoring fluid balance, but the exam question asks, which rationale best explains why frequent assessment of urine output is essential in this population? Here are the options to consider. Option A suggests that urine retention is common after a heart transplant. Option B emphasizes that urine output is a key indicator of adequate renal perfusion and cardiac output. Option C points out that hydration status determines when the client requires blood transfusion. And option D claims that hydration status helps guide when intravenous fluids should be increased. The correct answer here is option B. Urine output is a key indicator of adequate renal perfusion and cardiac output. This is because urine output is one of the most immediate and sensitive markers of kidney perfusion, which in turn directly reflects cardiac output in a newly transplanted heart. After a transplant, the heart may have temporary contractile weakness from ischemia-reperfusion injury, denervation, or early graft dysfunction. If cardiac output drops, renal perfusion falls, leading to reduced urine production. Therefore, oliguria, defined as urine output less than 30 milliliters per hour, signals inadequate perfusion and could indicate graft failure, fluid overload, or hypovolemia. On top of this, immunosuppressive medications like cyclosporin and tacrolimus have nephrotoxic effects, which makes monitoring urine output even more critical. In this context, frequent urine assessment is not optional, but a cornerstone in recognizing hemodynamic instability early and guiding fluid therapy, diuretic use, or inotropic support. Looking at the incorrect options, option A, which mentions urine retention as common after a transplant, is misleading. While opioids or anesthesia can occasionally cause urinary retention, this is not the main issue in transplant recovery. The true concern is perfusion, not retention. Option C, which links hydration status to blood transfusion, is also inaccurate because transfusion decisions are based on hemoglobin, hematocrit, and oxygen delivery rather than hydration. Overhydration can dilute lab values, but fluid balance does not dictate transfusion needs. Option D, which suggests hydration guides when fluids should be increased, oversimplifies the process. Fluid administration is a delicate balance after transplant and is based on hemodynamic parameters like central venous pressure, pulmonary artery pressure, and echocardiographic findings. Overzealous fluid replacement could actually harm the client by worsening right ventricular function or precipitating pulmonary edema. Moving forward with the Stancoast Pearl. In post-operative heart transplant clients, Urine output is much more than a kidney function marker. It is an early window into the performance of the new heart. Oliguria should immediately prompt evaluation for low cardiac output, nephrotoxic drug effects, fluid imbalance, or early graft dysfunction. That is why continuous intake and output measurement, paired with invasive monitoring, represents the gold standard in transplant care.